Welcome back to Corium. I'm Brian Gilberti, and today we're joined by one of our exceptional residents, Dr. Phoebe Draper. And we're going to discuss granulomatosis with polyangiitis, or GPA, which is a rare and life-threatening vasculitis that's crucial to recognize early in the emergency department. So Phoebe, it's great to have you here with us today.
Such an honor to be here. Thank you.
Okay, now let's dive right in and talk about a case.
Well, I was on a really busy emergency department shift, and the nurses pulled me up to the triage area to see this young woman, a 23-year-old female from Nicaragua. She was presenting with 2 weeks of shortness of breath and bloody cough, as well as some new leg swelling. When I walked up to see the patient in triage, she looked incredibly sick, very pale, tachycardic, with pitting edema in both of her legs. I was immediately concerned that she was ill, and so started to ask her some more questions. She told me that she was coughing up blood and even chunks of what looked like liver. Felt very tired, short of breath, and had never had symptoms like this before. I was concerned this patient could have tuberculosis, so talked with charge nurse, got her in an isolation room, donned my N95, and went back in to talk to her more.
Now, certainly alarming presentation, and I agree, the differential here is quite broad. Spoiler alert, the final diagnosis here is GPA. But before we dive deeper, Phoebe, can you walk us through the fundamentals? What exactly is GPA? How do patients typically present? And why is it essential for emergency physicians to identify this condition early?
So it's this vasculitic process that really affects the small blood vessels in the body. These blood vessels get inflammation that leads to necrosis. The organs that we usually think about with these diagnoses is upper respiratory tract, so sinusitis, otitis media, saddle nose deformity. The lungs are affected. They get nodules and even alveolar hemorrhage, which can be life-threatening. And then the kidneys, which can develop rapidly progressive glomerulonephritis and even renal failure. It's a deadly diagnosis if we miss it. These patients can develop multi-organ failure and pulmonary hemorrhage, as well as severe kidney injury.
Right, and this clearly underscores why early recognition is critical. Now, could you highlight some of the key red flag symptoms that should immediately alert us to the possibility of GPA?
It can be so difficult to pick up, you're right, but things that should raise your suspicion are chronic sinus symptoms and also having hemoptysis, or something like new onset pulmonary complaints and also having renal dysfunction, or this diffuse alveolar hemorrhage. So any patient that's coughing up bright red blood should cause real concern. Some symptoms can be a little bit more occult. This is the patient that comes in complaining of fatigue, weight loss, fever. Patients can present subtly, so it all comes down to pattern recognition.
Yeah, very well said. Now, let's say we have a patient with some of these symptoms and we start to think that this is on the differential. How do we begin to work them up? What test are we ordering here?
You know, the biggest mistake is anchoring on infection or malignancy early and not considering vasculitis in the first place. So I would recommend in the ED that you order basic labs, CBC, CMP, looking for anemia or AKI, urine with microscopy to look for hematuria or red blood cell casts that can be suggestive of glomerulonephritis, some form of chest imaging, chest x-ray or CT to look for nodules, cavitary lesions, or diffuse infiltrates, and then this ANCA testing, which is usually not immediately available in the ED, but is important for us to get the diagnostic process going. The real game changer is recognizing pulmonary-renal syndrome early.
Now, let's say we get the results back and they're consistent with GPA. Talk to us about the next steps. What should we initiate in the ED for management?
Really depends on severity. If a patient is stable, it is possible to do the workup as an outpatient. This would look like an urgent rheumatology consult and then discharging the patient on steroids, something like prednisone, 1 milligram per kilogram per day, and they would follow up with rheumatology in the outpatient setting. If the patient is unstable, this is somebody with multi-organ involvement, a significant AKI, or pulmonary hemorrhage, we would want to start high-dose IV steroids. This would be methylprednisolone, 1 gram IV daily for 3 days. We'd want to consider plasma exchange if there's severe renal or pulmonary involvement. And then thinking about cyclophosphamide or rituximab initiation, this would usually be handled by room. These are the patients that are going to the ICU.
All right, so a lot of important things to consider, and I'm glad that you made that distinction, that this is not your regular dose of steroids. This is going to be a gram. Now, vasculitis is a tricky diagnosis, and a lot of times we don't put that in our differentials, and that's why this episode is so important. Now, what are some other things that can mimic GPA that we should also consider on the differential?
On the differential is Goodpasture syndrome, which is a similar pulmonary-renal presentation, but with anti-GBM antibodies. Infectious causes, TB, fungal infections. We'd be looking for fever, weight loss, cavitary lung lesions. Lung malignancy can cause hemoptysis and nodules, but lacks the renal involvement. And other vasculitides, EGPA, MPA, lupus. These all have different antibody patterns and systemic findings.
Now, Phoebe, bring it back to step one for all of us. How useful is ANCA testing for GPA?
ANCA, the anti-neutrophil cytoplasmic antibody. It is helpful, but it does not rule GPA in or out. C-ANCA, or PR3 ANCA, is positive in 80 to 90% of GPA cases. P-ANCA, or MPO ANCA, is more common in microscopic polyangiitis, or MPA. We're not going to get these results back in time in the ER, so don't wait for ANCA to start steroids if suspicion is high.
Okay, very good. Now let's talk about why this is all so important. Tell us about the outcomes and how these patients do without treatment.
Without treatment, most patients die within a year due to the renal failure or some sort of respiratory complication. With aggressive immunosuppressive therapy, 5-year survival is about 75 to 90%. Relapses happen in about 50% of cases, so this long-term rheumatology follow-up is really essential.
Okay, so we went over some essentials here. Let's tie it back to the case. What happened to the patient, Phoebe?
Our patient had a really complex hospital course that touches on a lot of the pillars of treatment that we mentioned. She was started on high-dose steroids as well as rituximab and ended up requiring dialysis for acute renal failure.
Okay, very good. We covered a lot today. Let's cap it off with some take-home points. GPA can present subtly or mimic infections and malignancy. It's important not to anchor and include vasculitis on the differential in patients with unexplained respiratory, renal, or systemic symptoms. Key findings include hemoptysis, especially bright red or chronic sinus symptoms, new pulmonary complaints, renal dysfunction, and constitutional symptoms like fatigue and weight loss. Now, for unstable patients, initiate high-dose IV steroids, Solumedrol at 1 gram a day, immediately, and don't wait for ANCA results if the suspicion is high here. These patients often require ICU-level care and rheumatology input. Now, finally, untreated GPA is fatal in most within a year, and with prompt immunosuppression, survival improves dramatically. So that's why it's so important for us to recognize this early on. Okay, that'll do it for this episode. Phoebe, thanks for being in the studio with us.
Thanks so much for having me, Brian.